The reason why we will go for CBCT in cases of trauma is that 2D radiographs, all 2D radiographs, starting from the periapicals ending with the largest, like posterior anterior skull or whatever, they are two-dimensional and you lack the depth. So whether you have a fractured tooth or a fractured alveolus or fractured bone, two-dimensional radiographs might hide the fractured lines, the radiolucent fracture lines, especially if they are tiny or small. So you have, this is a normal procedure in cases of trauma, dental or whatever. Don't be satisfied with a single view. Always try to view the tooth at least two-dimensional, two radiographs, either with a tube shift technique, horizontal tube shift technique, vertical tube shift technique, or you can use for vertical techniques, so that you would see the missing dimension. So two-dimensional radiographs fail to show the depth, and thus the fracture line might be hidden. Second, in cases of trauma, especially when there is bleeding, whether moderate amount or massive amounts of blood, especially in big quantities, tend to mask the small fracture sites. So the small fracture again will be hidden by the bleeding site. And the third thing, especially in the fractures of the maxilla and maxillary complex, is a structure that is hard to be seen in two-dimensional radiographs because of the great deal of superimposition of structures. In the mandible, things are different. You have only the mandible, and then there is nothing that masks the image of the mandible. But in the maxilla, there is a great deal of superimposed structures, too many structures, plus the maxilla itself is a thin bone, so fractures tend to be hidden in two-dimensional radiographs. So, in cases of trauma, it is justified that you would go for a 3D examination. You have the CBCT, so start with the CBCT. Again here, try to maximize the field of view. Why? Because of the possibility of transmission of fractures to other remote sites from the fractured area, especially in the mandible, where you know that the mandible is a dense bone. So if a fracture forces will be transmitted to remote areas, and thus it will be overlooked. So go for CBCT with a large field of view. Okay, so ideal for cross-sectional evaluation of trauma, that is the 3D, and limited volume, high resolution CBCT is indicated. High resolution CBCT, it means some machines, they give you the chance to choose between quick exposure or a detailed exposure. Quick exposure in cases of, just you want to see, suppose you're doing an implant and then you want to see a quick 3D view, so this will be done with a reduced exposure time. In cases of primary evaluation, though, you don't try to avoid the quick exposures, go to the high dose exposures, so that you will see these will be high resolution images, of course, on the expense of the patient exposure. Okay. Root fractures, where the conventional intraoral radiographs provide inadequate, incomplete information for the treatment plan. In orthodontics, CBCT is not always or standardized procedure for planning the placement of temporary anchorage. in orthodontics. Large volume CBCT should not be used routinely. Again, we are considering the dose. And what would you do? You would be satisfied with OPG plus a lateral ceph. Why would you expose your patient to high doses? However, in severe cases of skeletal abnormalities, particularly those which required combined orthodontic and surgical procedures, then it is justified that you will go for the larger coverage craniofacial field of view, so that you will have a full understanding. In cases of planning, definitely you will need them, because 2D radiographs fail to give you the complete image of the area.